Thank you very much. Thank you, Margot, and thank you, Vicky, as well. I'd just like to say that that was not at all hyperbole, that a friend of ours who is a driver did indeed, I'm often not in Boston, and this is a friend of ours who, if I'll say, well, can you come pick me up at Logan? I'll say, well, it's awfully late, actually. All right, so he's not always available, all right? But he's you know all this, but he's a history buff, and we trade books as well. It's a very, and he said, you've got to do this. And I, of course, knew Margot through Howard as well, so it's a real privilege to be here. And I have to admit, I was a little bit surprised to learn that I would be here when the theme was laughter, because I would not say that global health is the most riotously funny of fields, but rather that one does need to have a sense of humor. I want to talk about the substance of our work, and I struggled a little bit about how to deliver this talk. Initially I was going to talk about facing history in the sense that a historian might, and because I, like many people, like Rick, my friend, our friend the driver, am fascinated by history, and it seems to me the most radically re-socializing of arenas, especially as you are, all of you, or many of you, students or teachers. All of us should be students or teachers. And so I'm a believer in that approach. And then, of course, as a physician, we have a different kind of history, the history of what's called the history of the present illness. And that means asking someone, a patient, well, what is it that's wrong? How are you feeling? Explain to me what is wrong. And so there's that history as well. But I thought it might be more compelling for me to talk about our work in global health and then return to some of these broader questions. I met with some students, Chicago public school students today, and we had a very bracing discussion. I thought I was bracing in any case, although one guy said, I'm really tired. So was it something I said? I said, no, I got up 5 a.m. to walk to school. He knows who he is. In any case, we had a bracing discussion, and we talked a little bit about some of the big issues. And so I'll frame this with a couple of complementary paradigms. This discussion of health and of global health with complementary paradigms. Now, I've used this a lot in my writing. By the way, where's Vicky? Where'd she go? I just want to say thank you for noting that I'm an author, because everybody says, I read your book. I find that deeply annoying. And I say, oh, really? Which one? That bestseller, Women, Poverty, and AIDS? Or maybe it was The Global Threat of Drug-Resistant Tuberculosis you read. But I just want to thank you for that, Vicky. Anyway. So I've used this, some of my colleagues are here. I've used this quotation, which is many times in my writing about health and social justice. I think that Martin Luther King, puts his finger right in the wound, that there's something really special about and troubling about disparities of access in healthcare. And I think that our country, my country, the country I was born and raised in, is struggling with this now. What can we do to face history as a nation, as people on this planet who now are living in this century of incredible technological and scientific promise? What does the social contract look like now in the 21st century? And I think for doctors, nurses, scientists, or future practitioners of healthcare, there's a lot at stake in facing recent history if we're interested in disparities of access. So that's one framework, and it's very congenial to me and to my many coworkers to talk about the rights-based models. But there are other frameworks at play, and some of them, of course, are in competition to a basic rights-based model, but not all of them are in competition. This I had to put up. Everybody has to use New Yorker cartoons. So I'll let you chuckle at that. You know, but I have to say, as a physician, sometimes we do feel beleaguered. We do feel beleaguered by the demand that if we are going to respond to the healthcare problems of people living in poverty, whether in Chicago or Haiti, or I'm going to Rwanda from here, it is difficult we don't have the answers to all of these questions. And the only way that we are going to solve the challenges or address the challenges before us is to, and I was happy to say this to the students, is to be part of a much broader team. And so instead of opposing a rights-based framework with an economically sound business plan, I'm not going to do that here. And I hope that I don't do that and have not done that in my own work. In fact, I know I have not. I'm going to talk about paradigms that we can use that are fully complementary, including this one. Can we or can we not break the cycle of poverty and disease? And I think the answer to that is an unqualified yes, of course we can. We have the technologies that would help us do this, although it's not going to be only a technologically driven response. And we also have, as our cherished social goals, equity, justice, and the sharing of scientific resources across all boundaries. And whether we talk about regional boundaries in a country or transnational boundaries, the ones I'll be crossing tomorrow, boundaries between the 5 boroughs of New York. But the answer to this question is yes, we can. We can break that cycle of poverty and disease. And of course, the devil's in the details, and so I will stick now for the rest of my talk until the end in the details. This is, and talk a little bit about our experience. Now, I was asked or invited by Facing History and others who organize this, I was invited to talk a little bit about my own experience. And I think that there's a limit to which one goes in talking about one's own personal experience when the topic is global health. But this is my short version of the story. That I've talked to the students about this as well. In college, I started reading Facing History in the sense that any student can. One of my former students, who's a colleague of mine, is from the great city of Skokie, was saying to the students, I went to a public school in this area, Niles North, at least I know the name of it now. And I met some students from Niles North today. He said he started this in high school. I did not. It was really in college. I was lucky enough to get a scholarship to college and started thinking and reading and really learning more about the world around me. And that's how in between college at Duke University and medical school at Harvard, I spent a year in Haiti. And it was a great struggle. And that was 27 years ago. And I went to a village, really, that I thought was about the most rundown place I'd ever seen. And it turned out that it was not a long-standing settlement, but was a squatter settlement of people displaced by a hydroelectric dam. I've told this story many times, written about it in my books, my best-selling books, like Infections and Inequalities. Surely, Vicki, you must have read that one. Actually, I have to be careful because this is on tape, and my publisher is wonderful, the University of California, so they might take umbrage if I was slighting. That's going to be our new development campaign, is umbrage. It will be taken. There, see, laughter. So in any case, I went to Haiti and in 1983 and was in this place where people were complaining all the time, as they had every reason to. They'd lost their land to a development project, and they'd been driven up into the hills. And that was a transformative experience for me. I've been asked before, well, do you have something against dams? And I said, well, why do you ask that? Of course I don't. And then the answer is because in my writing it sounds shrill, this critique of a hydroelectric dam. I was just reading I was saying to Margot and Judy and others who invited me here that I completed reading yesterday Jonathan Alter's book about FDR's, the beginning of his term, beautifully written book, in which you see the TVA, the Tennessee Valley Authority, for the power, not just the literal electric power, but the power that it brought to economic development. And I think there's no reason for any of us, certainly I do not feel any animus towards hydroelectric dams. The problem, as it is always, the devil's in the details, is that what happened to the people who live behind the dam? What happened to them? Somebody had to be thinking about them. And so I began the students with whom I met today were asking, what's the one thing that you would identify as significant in your life? And someone asked me, I'm sure she's here somewhere, was she from Orr? See, I'm learning the schools. What childhood experience shaped me the most? And I said, I'd be reluctant to answer that. Why? Because of my many brothers and sisters, one of them was a professional wrestler on television for 10 years. So there you go, making claims of causality. Same mother, same father, same everything, and he became a professional wrestler. So actually, I did not choose an event in childhood. And I reminded them that Franklin Delano Roosevelt, for the last 26 years of his life, and they knew this, couldn't walk. He couldn't stand unaided. And that happened to him when he was 39. And the event I would choose would be going to Haiti and learning from the Haitian people and learning about the two discrepant versions of reality that I had before me. On the one hand, the reports from officialdom about this very important and much-needed development project. We need hydroelectric power. We need alternatives to burning charcoal. And so we got this version of the report, but on the other hand was the story told to me by those who'd lost out in this process, who'd lost their land and had been displaced. So it gave me a lifelong and healthy skepticism for expert opinion. A respect for it, because you can't go into medicine, I would say, you cannot become a practitioner of modern medicine without a deep respect for for scientific method, for data, for critical analysis of information that really comes to us initially from bench science and then is often, tested in clinical trials. At the same time, there are many discrepant versions to any story. And sometimes that leads to this great cacophony. It does often for me. Where there's too many different versions of a story. And you realize you have to be discerning and understand which ones are not, which versions are hew most closely to what really happened. But that was the first experience for me. It was 27 years ago. And what happened next, which is, I haven't really written that much about this myself. It's not my work, but the work of really hundreds and then thousands of people. And we ended up in this squatter settlement, which probably was not the smartest place to build a referral hospital. I accept that critique. But we did, and then I'm not going to talk about that work, but I'm going to talk about some of the efforts that we've made since then. And, again, I didn't do this, my Haitian colleagues did, but it was a wonderfully instructive experience to have to respond to the demands that we heard from those who'd been displaced by this project, and they asked for the things that you might expect they would ask for. They wanted schools, they wanted medical care, and they didn't even get electricity and water when they were displaced. So a hydroelectric dam, and they never got either hydro or electric. They were living in squatter settlements with no power. So it was a good way to learn about many complex things, and and I'm just very grateful that I got to shuttle between Harvard and Haiti all those years and still do, as I just did last week, in fact. Now, but let me skip ahead. So that part of the story I got to tell to some of the students, and some of you read about it. Now, if you are sitting in a hospital, this is, by the way, a patient who I didn't see. It was sent to me by a colleague of mine, again, a former public school student from Skokie, Illinois. I was giving a talk on cancer last week, and cancer care, diagnosis and care in developing countries, or whatever we may call them. And I was looking, a lot of clinicians there, and I said, send me, I'd been mostly in Rwanda for the last few years working there, and I had plenty of cases, patients I'd seen and diagnosed and treated. And I just asked for some cases from Haiti. We're just pulling things together with some colleagues and former students from really all over Haiti, Malawi, Rwanda. And the Chicago dude sent me this, and he said, it's a 54-year-old man. This is what happens when you're facing history in a clinic, by the way. It's not like people are going to come in and say, well, I've got a very simple problem for you, doctor. I broke my arm. Please set it. That would be a treat, all right? But that's not what happens. Most of the problems people bring to us they're difficult, they're complex. And this is an example. This is a guy in his 50s who had lymphoma. And the question that you'd ask, once you've already built these infrastructures, this is actually in a different hospital, which is a public sector hospital. I'll talk about it in a second. It was actually built with a lot of help from people in Chicago, I've got to say. That's one reason I'm back here, is because we have a robust community of concern here in Chicago. One of our board members, Marjorie Benton, is not here today. She's out of the country, but a lot of you know her. And we have so many people, and I'm going to go back to some of the people who are helping us from Chicago, but you're one of the reasons that we could say to this guy, I wasn't even there, as I said, I was in Rwanda, you have cancer, but we know how to treat it. And the reason I'm using this example rather than others is the trap in my line of work, the biggest trap in global health, is to write people off because they're living in poverty. To use economic status of an individual to determine what should be the appropriate medical intervention, whether that be preventive or diagnostic or therapeutic. I got to say, that's one of the biggest and most troubling trap that I've seen, whether, again, we're looking at inside a country or across national boundaries. And I'm just warning people about and I warned the students today, don't buy these arguments why work here rather than there. We've got global endeavors to consider, again, whether they be within our country or across borders. And the administrative boundaries that we set up as human beings, we're stuck with that forever. But there are challenges across lines of place and class and language and country of origin. All of these things are the challenges that we need to face in public health. And anyway, I like this picture. I don't use a camera very much, but my colleague is a great photographer, and he also administered the chemo. And the reason I used this at this conference the other day is because one of the arguments, many arguments that are made for not intervening, which to me are still stunning after 27 years. One of them is, well, you can't treat cancer if you don't have an oncologist. There is not a single oncologist in the country of Rwanda. Not one. There's a lot of cancer, however, so we better have Plan B. And we already had this worked out in Haiti because we have a robust Haitian team who are of doctors and nurses who said, oh yeah, we know how to do that. We've been doing this for a while. Same guy, 2 or 3 years later, he's still, as far as I know, still around. And the reason I want to start with this vivid example is, as Margot said, our work is also about individuals. It's about one-on-one. And again, I wanted to choose a patient who I hadn't seen, who'd been seen in Haiti. Now, it is true that the diagnosis was made through the kind of solidarity that we're here to enjoy with the people of Chicago. And that is, in this instance, the diagnosis was made at a Harvard teaching hospital, the Brigham and Women's Hospital, where I have the good fortune to work. And what's wrong with that? That's great. We sent the tissue up, the biopsy, the diagnosis gets made. We steal the chemo. I'm sorry, we have a procurement. Okay. Actually, this project is with the Dana-Farber Cancer Institute. No stealing involved. You would not believe how much grief I get for making that joke. My coworkers are looking at me like, we told you not to say that. Let me make it very clear at this laughter conference, that was a joke. Happy now? So, one of the points I want to make is this was done in a public sector hospital. People write off the public sector, the government can't do anything. This is a public sector hospital run by Haitians. Many years later, yes, we help with the diagnosis, yes, we help with the chemo. This was delivered in rural central Haiti. And that's sort of the lesson in a couple of pictures. And I'll return to that again in the third hour of my presentation. So, to speed up the story is, these kind of interventions are really not about one place. They're about, and everywhere there's a red dot, from the Dominican border to the coast that was flooded last year and hit by 4 hurricanes, we have rebuilt infrastructure. And I'd like to, if I may, to asked you to give a warm welcome to my colleague Patrice Neville, an engineer who just arrived fresh off the plane from Haiti. If you would just stand up. Thank you. This man has built more hospitals in the last decade than you can shake a stick at, and he's here to, I sound like President Clinton there. I'm picking up his cadences you can shake a stick at. And he's here to work with, actually, if I may brag, a classmate of mine from college who is an architect, and she and her husband are Chicago architects, and they're working with us to design healthcare infrastructure. That's the kind of partnership that I'm talking about. And I'm hoping that we can keep on, I know we're going to keep on moving this forward, but he's here not to hear my talk. All my coworkers in Haiti are thinking, not Paul again, but rather to work with our friends in Chicago who are volunteering their services. Actually, there's a guy flying here, a construction, I like using the word magnet, even though I have no idea what that means. It's like tycoon. They're ill-defined terms. But a friend of ours who's a construction guy from Boston is flying from Boston to Chicago. We're all meeting in Chicago. I'm actually going to Rwanda News to talk about building this hospital. It's very exciting. And everywhere there's a red dot, we have gone into these public sector institutions and rebuilt this with the Haitian people and the Haitian Ministry of Health. And we're very proud. It's required lots of partners, and many of them come from, and a lot of the capital has come from the United States. But I think it's a real robust partnership and could be a sound model for other places as well. Now, why do I say that with confidence? Because we've been in other places. Working with President Clinton, the Clinton Foundation, and many partners, we have taken this model of integrated primary health care, and that's what this is about, is integrated primary health care in the public sector with private partners like Partners in Health and the Clinton Foundation, working with the local health authorities to rebuild infrastructure in rural Africa, starting in Rwanda and then going to Malawi and Lesotho, and most recently, as some of you read, to Burundi. That is the kind of partnership that we know works. And I'll give you some more examples from Africa than I did from Haiti. How do you do this? Well, it's not rocket science. I'd like to be able to claim that this model is just so ingenious that it deserves a patent. But it's not rocket science. You have to do several things at once. I believe that is the expression of our current president. You have to be able to talk and chew gum at the same time when you're doing this. And to do that, you need a big team. And what we have done is to say we're going to provide services, and that's what the doctors and nurses and community health workers do, more on that in a second, as we rebuild infrastructure, like Patrice Neville does, all the while where we're training and having formal feedback loops, which I've called here research, that is to learn from our mistakes and to share these insights with others. This is one of the main reasons, or the main reason that I work as a teacher, is so that we can transmit these lessons effectively. And so this is a before and after picture from, again, a public sector hospital, which in 2005 had not a single doctor in it. I mean, it was abandoned since the genocide. Some of you actually from Chicago, many of you from Chicago have been to visit. But it's not, this is the same ward before and after. And it is a public sector institution with a Rwandan staff, and a lot of us, including our Haitian colleagues, have gone there to help implement this model. Now, that's the infrastructure and services part. And I would add here, and again, we can talk about this in our discussion, but some problems are complex, some are easy. It'd be great if they were all easy. You know, I was talking to a family of supporters here in Chicago. We had lunch today, and we were talking about what is the model and what are the metrics, which is the right questions to ask. What are the model? What's the metric? How are we going to measure success? What we would argue is there are some very straightforward ways of measuring success or failure, such as life expectancy at birth, infant mortality, maternal mortality, and also the number of local people trained, which these days is called health capacity or capacity building, whatever you want to call it. We know what it looks like. But you need infrastructure. For example, if you have a surgical problem, chances are pretty good that you may need a surgery suite. I'm actually hoping, as I've said before, to win the Nobel Prize soon for the great discovery that surgical problems are best treated with surgical suites, and that the biggest discovery that I've made, I'm really proud of, is that I've discovered the cure for malnutrition, which is called food. But there are these straightforward things that you really need to do, and this is a big part of it. This is what we found, and you can't provide medical services with no infrastructure. At least I don't know how you can. And this is another picture taken in Haiti. It's obviously to show training, in Rwanda. But these are my Haitian colleagues in Rwanda. So again, I'd like to, talk about facing history. I already explained that I was facing history in a sense when I was lucky enough to end up in Haiti, but obviously I have been the student of Haiti, not just Haitian history, but my colleagues from Haiti who have done wonderful work in Rwanda, Lesotho, Malawi, and in Boston as well. So I'm very grateful to them. And then, of course, we saw the same kinds of stories. I've shown many people will think that this is the same picture I've shown before when I was here. It probably is not, because this is not a patient from Haiti, it's a patient from Rwanda. And I got into a little bit of trouble when I said he goes from looking like Skeletor to needing Lipitor. But this is the effect that was predicted. I've told that joke before, I must confess, but but the effect that we predicted on morale also of our peers in Rwanda, and I remember, it's one thing to have me go into rural Rwanda and say, we've got to rebuild the hospital, we've got to do this, we've got to clean up, clean the windows, we have to receive the patients with dignity. Okay, it's fine, I'm proud to say that. I'm glad I get to play a role in that. But I think it was a lot more compelling to have my Haitian colleagues come in and say, hey, buck up. This is going to work out. You'll see patients like the ones we saw in Haiti who come back from the dead. And of course, sure enough, this happens. In fact, I would say it happens inevitably. There is no exception to that rule. If you see patients who have a treatable ailment, this guy happens to have AIDS and tuberculosis, who are offered access to high-quality services, you see transformations like this everywhere in the world that you work. And whether that's going to be, in this country or in, Africa or in Asia, it doesn't matter. We have some tools that come largely out of modern science, which, if delivered equitably, will change the way that we respond to social problems. I believe that. And I think it's something we need to push forward now. Now, I want to close with some reflections on returning to Haiti. And it's not as if I left Haiti, it's just that I've been working mostly in Africa, and I was actually talking to, this sounds like I'm hobnobbing with the powerful, but I was talking to President Clinton in Rwanda in August of 2008, and he was talking a lot about Haiti. And I went back to Haiti, and in the middle of what would prove to be 4 tropical storms, 2 hurricanes, 2 tropical storms. And if I had asked the students earlier today, this didn't come up, I'd ask them, well, why is this area so vulnerable? They would have said, because of deforestation. And that's right. So this is the city of Gonaïves, and I had never seen anything like this in my whole life, with all these people displaced, an entire city underwater, except one other time. And you think I'm talking about Katrina, but I wasn't there. I actually, now that I think of it, I was in New Orleans right before Katrina, and here I was in Gonaïves right. This is starting to sound bad. In any case, I left New Orleans. I'd been giving a talk at Tulane, and I went from Tulane back to Rwanda, and so I watched the whole spectacle of Katrina from Africa, and it was a very difficult thing to watch from Africa. The kind of comments that I got from my Rwandan colleagues, we had set up, we put in place as part of our work, our medical work, put in place access to high-speed internet access so people could watch all of this stuff on their computer screens. And, it was very, very difficult to watch as an American as we, flubbed our response. The only time I'd seen this person was in the same city in 2004, when Gonaïves, that's how you pronounce it, was hit by Tropical Storm Jean. And actually, Gonaev was not hit by tropical storm Jeanne. Jeanne hit Cuba much harder than it hit Haiti. But Haiti, again, where heavy rains led to massive flash flooding, flooded this city, which is on a floodplain. But it was the second time, and it was extremely troubling. And I wrote a piece that some of you read and responded to. Suzanne, my colleague from Partners in Health, had suggested I do that. I wrote a piece from Haiti and said, look, we're going to have to respond here as disaster relief people, even though that's not what we know how to do. And all of our team did, by the way. But to do that, we had to have resources. We had to have food and shelter. So I sent out this appeal, and I couldn't send the email from this city because all the signal was gone. So I went back to central Haiti and that night, another hurricane hit Haiti, Hurricane Ike. And so the bridge that we had crossed over to get back into central Haiti was swept away that night. It was the 6th or 7th bridge to go. And so, these are very dramatic problems, but they're really problems that come out of history itself. And I want to close with that thought and open it up to discussion. I already said I'm going to close on that thought 3 times, and this is a ruse of mine. But this is what a lot of Haiti looked like after that. These are fields of crops that were just destroyed. Haiti lost 16% of its GDP in 1 month. It was terrible. And now we're still dealing with that in terms of food insecurity. And so, how do you build back better, to use President Clinton's terms? What are we doing? That, by the way, the number of people in Chicago have helped us to do that. So one of the things that we've done is to say, okay, we're going to respond to the acute needs, which is medical care, food, shelter. I mean, people walking in bare feet in a flooded city, they get cuts on their feet because they step on glass and other awful things. So people need first aid and water, and they need attending to right away. That's part of what any doctor, nurse, or community health worker should do. But we also have these deeper causes of the malaise there and elsewhere. And there are things like erosion, deforestation, lack of jobs outside the agricultural sector. So linking those kind of direct responses to these longer-term investments in letting Haiti build itself back better and not be dependent on the kindness of strangers is really a big part of what we're setting out to do. Now, how do you do that? I was just in Haiti last week to try and pitch, really, what I was thinking of as a food security project, but what tilapia farmers regarded as a sound business investment. Again, back to those first 2 slides. I know that we need to respond to hungry children the only way we know how, which is to make sure they have enough to eat. I also know, you don't have to have a PhD in economics to know this, that we need, for real food security, you're going to need food sovereignty. You're going to need some extent of control by local people over what it is they eat. And I was very impressed by a number of efforts here, just some images of local farming endeavors for my colleagues in Haiti, including this fish tank is actually not in Haiti, it's near Port-au-Prince. But soon enough, I would hope we will have hatchlings up there in central Haiti as well. It's a very impressive idea. That's the food part, but also there is this problem. A number of you have seen this image. And if I were to, again, ask students I met today, where do you think this is? They would probably know that's the Haitian-Dominican border. And this is in the rainy season as well. So this is about as green as it gets. But on one side of that border, no trees, and on the other side, other trees. And the cause of this are not some local cultural shift that suddenly happens on that border. That's an absurd claim to argue that it is Haitian culture that suddenly shifts on that border and suddenly there's a culture of loving to cut down trees. And believe me, there are people who believe that. And it just doesn't make any sense. First of all, there's enormous cultural and linguistic homogeneity on both sides of that border. This is really about other causes. And knowing how to reforest in the middle of an economy that demands that people cut down their trees to make charcoal and cook their food, that's going to be the challenge. That's how we're going to face history in Haiti, is letting Haitians drive this process forward themselves and sharing with them some of the fruits of scientific knowledge and development, which was my claim all along about global health tonight. And I think we can and will do that. This is just one of the things that I was very happy to see last week. There's a number of pictures, but one of the things I was happy to see was that one of the hospitals that Patrice rebuilt, we met on Friday as well in Haiti, was now crowned by a 10 kilowatt generating set of solar panels. And initially they said, well, Dr. Farmer, climb up on the roof and look at it. And I was thinking, I don't want to climb up on the roof. But I did, and I'm glad I did. It's very impressive to see. And then I started talking to the solar guys, and they explained to me the business proposition as well. And one of the things I can tell you is, I think that for us to face history and look forward as well, we obviously need alternatives, not only to charcoal, but some of the fuels that we know are going to continue to damage the environment. And I'm not saying there's any panacea in solar power. What I am saying is it was good to see that this was also a sound business proposition for anybody interested in reducing their expenditures for fuel, which of course is a great concern of ours as we're raising capital in order to fuel these very ambitious endeavors across Haiti, but across Africa and elsewhere where Partners in Health works. And I was given a specific figure from my colleagues that in the month of, 1 month before this went up, it was just recently, I forget what, I think it was just a few months ago, we had spent to run this hospital in this town, we had bought something like, let's just say it was 20 barrels of diesel to fuel the generator. This is off the grid, as 95% of Haiti is, believe it or not. And the next month after installing this, it had gone down to 1 or 2 barrels, which was largely because we had some big ticket draws from like an X-ray machine. And we'll figure out those problems too, as long as we work in partnership to both face what came before and look forward to what we can do better in the future. And that's going to require working again with local people, not just engineers like Patrice Neville, but people who can find alternatives to charcoal. This is another image from a local program in which instead of cutting down trees to make into charcoal briquettes, they're using other kinds of agricultural waste. I started learning you can make charcoal briquettes. It seems to me just about out of anything, like plastic, glass, fake plants. So, anyway, it's not my field. The point is, it doesn't need to be my field. It needs to be our field, our collective field. And then finally, to be more grand, I said I would. I asked a number of the students if they knew who this was, and most of them allowed that they did not, nor would I have known. But in 1968, from what I'm told, this man who was born in the same town from which I retreated in Haiti after the floods, born in the same town, was named the founder of Chicago in the 18th century. And I know there's a museum of history that bears his name here. And it seems to me that to come from Haiti to Chicago and back to Rwanda, it's important to remind ourselves of not just the recent history, but also the history of our past, our country's past, this region's past, the difficult questions that are posed very often, including by my colleagues in Facing History, asking the hard question in the hope, the Enlightenment ideal, that if we ask these questions now, we can avoid some of the most painful chapters of our recent history. And by recent, I mean not only the slave trade in the late 18th century, but also, of course, the violence that we saw in Europe, especially in the 20th century. And I think that is a gamble well worth taking, and it's why many of us are here. It's what brings us back to Chicago, the idea that we can make common cause to improve the well-being, not just of the people we serve as physicians, but also of the entire planet. So I'd like to thank you and look forward to discussing how we can do a better job working together in the future. Thank you very much.
Hello, Dr. Farmer. My name is Ruchi Patel. I'm a senior at Niles North High School.
But I already know you're a senior at Niles North High School.
Which has made an effort to raise funds for Partners in Health. Can't hear. Move your mic farther. Huh?
Maybe you should just hold it.
Oh, I think I just broke it. Oops. Sorry.
You're doing good, Reedy. You're doing great.
All right, okay, good. All right, see, at least they're laughing.
Go Niles North.
Thanks. I think what you do is amazing and very inspiring, and I'm honored to have this opportunity to meet you. My question for you today is, when you define healthcare as a human right, what does it mean to you?
You know, I think in a way there's a specificity and a generalization, talking about healthcare as a human right. The specificity, for me, comes out of clinical practice. So even though I've discouraged you guys from focusing only on time and space, like being in a certain, I mean, I'm you know, an American citizen, very happy to be in it, very lucky. And I encourage you guys to think globally and to look back deep in time. That said, the real challenge in fulfilling rights probably happens locally as well, in the clinic or in the school or in, you know, in the flood zone. So how do you link those two things to make human rights meaningful and to understand, you know, good analysis of human rights? I would say that there's almost a theoretical challenge. I would never, by the way, I would never have said this 15 years ago or 20 years, much less when I was in high school. So I'm trying to share with you things that I've learned in this work. And that is, it's probably important to think about public health and public education, the so-called government sector. You're in a public high school like I was. You're both in public high school. Partners in Health is a private NGO. You know, it's an NGO, non-governmental organization. But that doesn't mean that the non-government organizations can't work to promote public health and public education. You know, why I say this is, and I've said this to my colleagues many times, who confers rights? So the right to health care, the right to clean water, the right to, probably not a church group or an NGO or a university or a high school in Chicago can't confer rights in Haiti or Rwanda. Probably the public sector has to do that. So finding ways to connect with public health and public education, I think, is a really important thing to do. And it's not easy to do. Some places easier than others. So that's what human rights means to me. It's listening to people when they say, look, we need housing, or we need, you know, what am I going to say? Sorry, I was trained in medical school. I'm not interested in solar power. You know, don't think it's not tempting to say that. But that's not an acceptable response. What we really should say is, we're going to work with broader groups of people to help everyone realize certain basic birthrights. Mm-hmm. And I think that's a struggle that it was a struggle when Social Security was founded. It's always been a struggle. It's a struggle in the human rights, civil rights movement in the United States. It's probably one of the reasons. Certainly, it was a struggle when people's rights were being diminished, attacked, or abrogated in Europe. So that's the specificity of your own action, your engagement, and the larger question of what should we do long term? Maybe not you, but all of us together.
Thank you.
Thank you. You know, someone said to me today, boy, you really don't give short elevator speeches, do you? And one of my colleagues came to my defense. She said, well, it's a complex intervention, and for Paul to give an elevator speech, he'll need a very tall building. Thank you for that.
Hi, my name is Sharice Howard, and I'm a student at Dunbar High School and also a member of Face and History student leadership team. I am currently studying to be a nurse.
You're a senior.
Yes, I am a senior.
I pay attention.
And my question to you, Dr. Farman, this evening, after all that you have accomplished, do you have a sense of satisfaction? How do you set your goals and decide what's next?
Oh, I just love these easy questions. You know, I think that there's a difference between satisfaction and self-satisfaction. And, you know, by most conventional metrics, you know, I would just say, how are we doing on winning the war against poverty, against, you know, let me just take some grand issues. Like, I don't know, as we say in New York, I don't know from global warming. I don't know it. I just think that there is a serious environment. I've seen it with my own eyes, so I showed you pictures tonight. You know, I know that environmental degradation is a severe threat to the well-being of the planet, but especially to the vulnerable. And I showed that's why, back to your question about human rights. Well, look at that city that's flooded. Look at what happened, in New Orleans. The idea that that's not related to the environment, that's absurd. Of course it is, right? I showed the example from Gonaïves. Yes, it's in a floodplain, but the mountains that surround it are denuded. There's no trees. So I've seen up close and personal what it's like to not be doing so well on the environmental justice front. So I think it's important to be very critical of how far we've come, which is to say, not far enough, especially if we look at the globe, or the world is. I wonder where that expression came from. The world is your oyster. Would someone Google that, please? That's what my daughter says all the time. Just Google it. I'm embarrassed to say that my response not too many years ago was, "Is that a verb?" But I would just say I think that no, we don't have reason to be satisfied. But what I think is satisfying is that in your generation, and in, let's just say people, your age, people on college campuses, people in medical schools, there's a great deal of interest in global health and global justice issues that I didn't see, frankly, 2 or 3 decades ago. Now, why this is so, I don't know. Why is there more interest? I'm not sure. I would make some guesses that have to do with information technology, some of them burdensome and silly. Like, I'm not going to say twittering silly, but it sounds kind of silly. Probably the person who invented it is here and is just not going to give us a check to support our work. But that's probably related to some of the reasons there's so much interest. And as I said to you guys earlier, you guys are my retirement plan. So the one satisfaction that I get is seeing how many young people are involved in these issues from your generation. So I commend you for that.
Okay, I have another question, actually. As an American, what challenges have you faced when building these facilities in other countries?
Yeah.
You speak many languages, I know that.
I speak 17 languages.
Yes. I don't think that many. I know you learned them quickly, at least. What other skills are necessary to be successful?
Well, that's a great question. I'm just gonna say that the good news is that if you are involved in community-based work, and you're not trying to replace other people, local people who could do this work, that's an important part. So I'm lucky enough to be part of a team. Just let me give you some numbers from our work. Is out of the 4,000 or 5,000 people who work with us in Haiti, 99% of them are Haitian. So it's and what we're trying to do is to listen to what, there's a false trap too. So if you only say we're going to listen to what everybody says and do exactly what they say, I already said that there's cacophonous and discrepant versions. Remember I told you the example of what's to be done. We need hydroelectric power, but we don't need to forget about people who live upstream. So you do have discrepant versions of what to do and what really happened. I understand that. And that's why I think it's really critical to listen to poor people. And people are, say, if you're gonna talk to people about cancer, it's probably good to talk to cancer survivors or cancer patients. I would say that kind of thing is always the right way to proceed. At the same time, you also want to talk to cancer doctors, or I don't know why I'm still going on about this example, and specialists in the development of new tools. And sometimes those are going to be the same people, sometimes they're going to be very different people. So that's one trick, as an American, or any representative of any other country, remember that you're working as a member of a team, and make sure and. Now, I don't want to use cliches like grassroots, but they're not bad expressions. And another term that gets abused a lot is the community. Well, what does that mean? Now I have to. If I could think of some Tony suburb of Chicago really quickly, it would help. Somebody help me out. What? I messed it up already. But everybody lives in a community. And when we talk about listening to the community, I think we should be specific about what we mean. I'm trying to be specific about what I mean. Mm-hmm. We need to listen not just to the community of professionals, Haitian professionals. I'm here with my colleague who's an engineer, but also the people who are facing these problems. That community is really important to solicit their opinion. That step is skipped over way too often in development work, and even in medicine, where it should be impossible because you're supposed to be listening to the patient and the patient's family. So that's one thing. The second about language and culture. Again, let me be very humble about this. If I'm working in rural Malawi, I must confess I haven't learned Chichewa. Have you?
No.
And I'm really glad that I had the opportunity to learn, about another place and other languages. But that isn't the indispensable part of this work. You can always work with other people who speak those languages. So when I work, when I'm lucky enough to go, as I was earlier, maybe 10 years ago, was going back and forth a lot to Siberia. Although I suspect that not many people have uttered that comment before, when I was lucky enough to be going to Siberia. But I felt that way, actually. It's a beautiful place. And I was working with, patients. I didn't speak a word. I couldn't speak. I could speak a word of Russian, but I'm saying I didn't learn the language. By that point, I learned to recognize what it is I didn't know and couldn't possibly have time to learn, and work with other people. And I think that's, again, it's the same lesson in a way. It's like you don't have to, in your own quite reasonable quest for personal efficacy and excellence, that's a good thing for you to do. Do that in academics. We were talking about this earlier, with the other students. You should continue to pursue excellence and personal achievement. That's your job, especially as a student. At the same time, don't fool yourself into thinking that you, personally, can solve every problem. If I start thinking that I am going to be better than my friend who is an architect, well, I am better than she is, but yeah. If I'm thinking I'm a better architect than she is, that's a big mistake, right? And so if I think I know more about, fuel and food than other people who are experts in the field, that's a mistake. What I know is how to connect people who are, need a hospital or need to talk about food insecurity or facing these problems with others who are experts and willing to help. So that's a second lesson I've learned, is just remember you're part of a team, and you don't have to know everything. You're allowed to choose some things that you know well. And if you and then finally, facing history in the sense of knowing that we are lucky enough in this room, for example, in this room tonight, we are very unlikely to go hungry tonight, right? That's just, and we're very unlikely to have the roof collapse on us tonight. And we're very unlikely, to die of frostbite. Although this is a city in which it happens, I'm told. I personally almost had frostbite on my way over here 2 blocks outside. Truly. I'm looking at Roxanne. Do I really have to walk outside again tonight? Yeah. So they were taking you to a nice restaurant. My first question was, do I have to walk outside? But in any case, what I'm saying, that's not going to happen to us tonight. But somewhere in the world, you can bet, a roof is going to collapse, or some dreadful violent event will happen, or people are going to, bed hungry, or children are dying unattended. And, I think acknowledging our place in the world is an important exercise to do. And it's a difficult thing to do because we define ourselves in terms of local engagement and family, and community for us means something local. So it's a tough exercise, but worth it. Concision is not my strong point. These were the kind of discussions I was hoping to have, I gotta say. These were the kind of questions I wanted to talk about. The substance.
My second question to you, Dr. Farmer, is, in my experience, people sometimes don't want your help. Have there ever been times where a patient or a family did not want your help? What did you do?
Yeah. Well, that's a terrific question. And I think that, and the short answer is yes, of course. Okay. But then coming to understand what was going on is a very, very important thing to do. And I got to say that my lesson, the lesson that I learned in all the places I've worked, including Boston as a doctor, is that it's really almost never as simple as that someone doesn't want your help, or that a family doesn't want your help, a patient doesn't want your help. They have their reasons for framing rejection of help, by the way, which happens very, very rarely. But in those rare instances it occurs, the reasons are usually something worth knowing about. So let me give some specific examples, from my own work. If I have patients who have, let's say, tuberculosis, who say, no, I don't want treatment, the more you look into it, the more you're likely to find out that they've already had several courses of treatment that have not been well designed or well conceived, or they've been ill-advised on what the right treatment is, or they've been denied the best treatment. It's usually almost something like that. And that's been this whole area of what's called non-compliance. People who don't comply with our expert advice. There are often reasons. And understanding those reasons, saying, okay, well, what can we do to make it more likely that our help will be helpful and our advice will be followed if it's good advice. Because you look back to just 50 years ago. This is what I meant at the beginning of my comments when I said the scientific revolution in medicine only is happening now. 50 years ago, look at the kind of advice doctors and nurses gave to people. That's not very long ago. People in this room, I was talking about FDR. Remember I told you I'd finished the book last night? And I was at some friends, they're here tonight, some friends of mine who live in Lincoln Park, big supporters of Partners in Health from Chicago. And in their living room, we were talking, and I was talking about Roosevelt, and someone said, well, I voted for Roosevelt. It kind of made my day, But if you look at what was happening then in terms of medicine, in the 30s and 40s, again, my mother wasn't born until 1937. So it's kind of after her time, but that's not that long ago. That's just yesterday in terms of facing history. And the medical advice was very bad. Like, we didn't know what we were doing in medicine. And only now are we acknowledging in my field that we have to catch up with the scientific revolution, and we also have to learn how to give advice more compassionately, more correctly, more justly, with this broader understanding. And I think then if you do that, you'll see that 95% of the time people don't reject your offers of help. But being patient enough, humble enough, as we were saying earlier, to listen and learn is a big challenge in medicine and public health. It's a great question. Thank you.